I'd first like to introduce Dr. Heather Hirsch. Dr. Hirsch is an instructor in medicine at Harvard Medical School and a faculty member in the Division of Women's Health here at the Brigham, and the clinical program director of the Menopause and Midlife Clinic. Thank you, Dr. Hirsch. She's going to be speaking on menopause management in 2020.
Thank you so much for having me. So we will go ahead and get started. So here are my conflicts to disclose. I have been a consultant, and I also have a podcast, Women's Health by Heather Hirsch, that I have had Uberlube as a sponsor for. So today we're talking about my favorite topic, which is menopause and midlife, because the scope of the problem is rather large. And on top of that, education can be lacking. So this is a great time for you to really catch up on a lot of that menopause education you may definitely need. Since you are all internal medicine clinicians, you are definitely seeing menopausal patients in your office reporting complaints that don't maybe seem classically menopause related, but surely maybe. So I really want you to take all of this information and really dissect it all. The average age of menopause in the United States is 51 and a half, and of women who are menopausal, about 70 to 80% are symptomatic. About a quarter of those patients find their symptoms to be very severe, meaning they're affecting their daily quality of life. They're affecting their ability to thrive, to function, to work. Now, there's several myths about menopause. One of the biggest myths I correct all the time is about how long menopause lasts for. There's sort of this myth that it lasts 1 year and then you're back to normal. But really, symptoms tend to last on average 5 to 7 years. About 10% of women, symptoms will last until their very last day, and about 10 to 15% of women fly through like it is just very easy breezy for them. Symptoms can also start in what we call perimenopause, that time leading up to menopause. So commonly, I hear patients say they have been told that you can't be having menopause hot flashes if you're still having periods or you're too young. And those are simply untrue. So symptoms can surely start in perimenopause when women are still having periods. And we know that for women whose symptoms do start in perimenopause, their symptoms tend to last longer and they also tend to be more severe. On top of just what we see clinically, there's deep-seated myths and there's also misconceptions about the treatment, about hormone therapy in specific, which we're going to get into. So menopause symptoms are so often under-recognized, mistreated, or misdiagnosed. And lastly, there's a lot of economic downfall for women who have or go without treatment when their symptoms are very severe. So there's not just one type of menopause. Now, natural menopause is, any type of menopause that's, over the age of 45. Again, the average age is 51. And that's really what this presentation is geared towards. So I really want to make that clear, but there are certainly other types of menopause. So surgical menopause, that's the removal of both of the patient's ovaries, is really a little bit different. Sometimes can happen earlier, not always, but often it can be sometimes a little bit earlier. Again, if the uterus is left in or if the uterus is or if the uterus is removed, surgical menopause is when both ovaries are removed. Early menopause and also premature ovarian insufficiency are also clinically extremely important, and again, are not really covered necessarily in this presentation, which is geared toward natural menopause. But early menopause is menopause between age 40 and 45, and premature ovarian insufficiency is before age 40. And the gold standard is to use hormone therapy for those patients because of the risk of cardiovascular disease and osteoporosis and simply quality of life for our younger patients. So take that in mind. There's not just one kind of menopause. Symptoms can be wide. Of course, hot flashes, night sweats, and night awakenings are something you're going to hear so commonly. But several other things are also very common that are somewhat or can be vague. For example, brain fog or trouble with memory and recall in an otherwise healthy, 50-year-old female, sexual health concerns and painful intercourse, We're going to touch on genitourinary syndrome of menopause, but that vaginal atrophy, which can also cause burning with urination or frequent UTIs, is extremely, extremely prevalent and important. Weight gain, you see this, I'm sure, in all of your midlife patients. Mood changes in someone who otherwise has never had any type of mood issues or may have some baseline mood issues, but all of a sudden are out of control. Again, hair loss, even vertigo, some of these symptoms can be related to the patient's menopause. And it's not a coincidence to me that these happen at the same time as women are starting to lose their endogenous estrogen. So I talked briefly about the economic downfall, and I just wanted to touch upon this. And this is really great work from Phil Sorrell, who is at Yale, who's done plenty of work looking at women who go untreated, who have severe symptoms. And in a large study, what they found is that women who went without untreated symptoms actually per person cost about $2,000 more. And this is direct and indirect costs of healthcare, meaning seeing more doctors, missing work, etc. And for that whole cohort, that's really $400 million in essentially lost revenue. Again, direct and indirect consequences. You all have seen the patient who may be coming to you with weight gain, hair thinning, trouble sleeping, and that patient sees an endocrinologist, a sleep physician, a psychologist, and essentially maybe all of these things are menopause related. The big consequence of not treating as well is the unregulated, compounded, non-FDA approved hormone therapy industry. And wherever you're watching, this is a big and significant and growing field. So essentially, when some of the dangers or worries or concerns or just misinformation around hormone therapy came out in the early 2000s, hormone therapy dropped off and the use of hormone therapy, FDA approved hormone therapy, declined. But at the same time, compounded non-FDA approved hormone therapy really started an uprising. They found a niche and sort of under these wellness clinics or etc. You may have plenty of patients who are using compounded creams and applying all types of estrogen or progesterone onto their skin and testosterone or maybe pellet injections, which are really, really much more dangerous than FDA approved hormone therapy. So as we get into the studies covering hormone therapy, you really want to weigh this with, while there are risks to hormone therapy, women will also go out and seek these elsewhere where they're probably more dangerous. And this is $8 billion industry, surely. Consequences of not treating, we've talked about economic consequences, the use of unregulated FTA hormone therapy, which can increase all types of uterine cancer or supertherapeutic testosterone levels. Of course, we have quality of life issues. I see patients after patients tell me that so many things in their life are really abruptly falling apart, including their ability to function at work, their ability to thrive in their relationships, their social relationships, so many things. So it affects so much of a woman's life. And as well as chronic diseases, either there's an indirect relationship, maybe there may be even more of a direct relationship. But if we're just talking indirectly, when women don't feel well, when they're not sleeping, when their mood is disrupted, they might have propensity to binge eat or overeat or gain weight, not exercise. And you can definitely see, even if we're completely arguing they're not related, but they're indirectly correlated, this can lead certainly to insomnia, high blood pressure, the beginnings of prediabetes, etc. So not only is there the economic downfall, the quality of life, but there's also just the worsening of chronic diseases that's really important to think about the woman as a whole person. The likelihood of prescribing hormone therapy is an interesting thing to me, of course, because I teach and, I get to see residents and medical students hear me discuss the consequences, risks, and benefits of hormone therapy. And this was a study done by Taylor et al. And essentially they were looking at OBGYNs and internists and their likelihood of prescribing hormone therapy based on true false questions as well as clinical vignettes. And the hypothesis was the more you knew about hormone therapy and the research and the studies, the more likely you were to prescribe hormone therapy. And that's really exactly what they saw. But I do want to point out that the mean score on the true false questions among internists was a 2 out of 9. So, after this lecture, I really hope you'll have some more knowledge that we can, increase the evidence-based knowledge, as well as point out that among GYNs was only 4.5 out of 9. So those doctors we may be sending our patients to, sometimes are not that much more knowledgeable. And really, I do have to say this is a topic where internists really do have some great skills because you're managing something chronically, and you're also dealing with patients' other chronic conditions, and you know that patient very well. So it's something internists should really be aware of. So I talk about the swinging pendulum in hormone therapy, and in the 1980s, hormone therapy was used shortly after menopause and was found to be somewhat beneficial. And in the late 1990s and early 2000s was when the scientific community began to do the first and well-known randomized study, the Women's Health Initiative. Now, after the Women's Health Initiative was lots of confusion about hormone therapy, and we're going to get into why. When the when the results of the WHI came out in the early 2000s, when the study was ended early, hormone therapy did decline in its use. However, we're going to talk about the long-term post-hoc analysis from the WHI demonstrating particularly benefits for women who start hormone therapy within 10 years of menopause who have no known contraindications to the use of estrogen. So let's figure out how we got there. So the Women's Health Initiative was one of the largest randomized control trials that I know of, that many people know of. And a lot of actually the safety data and a lot of the data that we do know about menopause and the use of hormone therapy comes from the WHI. So it was a randomized controlled primary prevention trial with the primary outcomes being coronary heart disease, non-fatal MI, and cardiovascular death. But importantly, the trials were not designed to control menopausal symptoms, and only a fraction of the women were actually symptomatic and having hot flashes. So that's a really important point to note, especially if we're extrapolating this to patients who are younger or symptomatic. Now, there were two arms of the WHI. And importantly, there were those who had an intact uterus and then those who had a hysterectomy. Now, of course, a main learning point, if you have an intact uterus and you're going to be taking estrogen, you also want to give that woman a progestin to protect her intact uterus. Whereas if you've had a hysterectomy, since the main role of progesterone is to protect an intact uterus, you can use estrogen alone in that woman. So in the WHI, they had two arms. The first arm was the women with an intact uterus. It was about 16,000 women, and they were given one dose of oral conjugated equine estrogen and medroxyprogesterone acetate. And that's important to note. And over in the women who had hysterectomy, they were given just conjugated equine estrogen. For that same reason, no need to use the progesterone. The study was planned to go for 8 years, but it stopped early in the estrogen plus progesterone arm, actually because of safety threshold concerns, but actually not in the estrogen only. Now, the idea was to actually get women who are younger, but actually the cohort was a little bit older. And that's because I always say women who are menopausal or in their 50s are doing so many things. They're at the peak of their careers. They're taking care of their children and their elderly parents and all of these things. They're busy women. So potentially because of this, the WHI did enroll women who are on average about 63 and a half. So importantly, that is about 12 and a half years out post-menopausal. If again, we're still calling the average age of menopause in the United States 51 and a half. Certainly some women are in their late 40s, and some women are in their early 50s. And only 17% were within 5 years of menopause. And that's really important as I start talking to you about the timing hypothesis, which we're going to get into. The timing hypothesis actually is what most NAMS certified physicians, and that stands for the North American Menopause Society, now recognize as the sort of window, if you will, or there's the timing hypothesis, this window where long-term data from the WHI really shows that women who are younger, within 50 to 59 or 10 years of menopause, actually have several benefits when using hormone therapy within that time frame, who have no other known contraindications to the use of estrogen therapy. And when I have more time, I typically will talk about the data in the post hoc years, but we're going to skip ahead to 2017. But first, I do just want to point out the second half of my slide here, which shows that the long-term data shows that women on hormone therapy who are 50 to 59 or within 10 years of menopause have a decreased cardiovascular disease, decrease in all-cause mortality, as well as reduction in menopausal symptoms and improvement in their quality of life, bone prevention, and prevention of new onset diabetes. Now, importantly, hormone therapy is not used currently today as a primary prevention for heart disease or all-cause mortality. However, this is just the data that we see. Now, again, I do want to point out that when those first trial came out in the early 2000s, all the women who are aged 50 to 79, all that data was combined. So it wasn't to the post hoc analysis where women were divided between their ages, 50 to 59, 60 to 69, and greater than 70. And that's where that timing hypothesis window comes from. So this is data from 2013. I'm actually going to go forward on this slide because I just want to focus on the most recent, which is the 2017 data. Now, this is 18-year follow-up of the women who were participated in the WHI until the study closed, and showed that all-cause mortality was 27.1% in the hormone therapy group versus 27.6% in the placebo group, although the confidence interval did cross 1. In younger women, the HR for all-cause mortality was 0.61, did not cross 1 during the interval phase, and then 0.87 during the cumulative 18-year follow-up, demonstrating some of the benefit did last after the patients or after the enrollees were off their hormone therapy. Hormone therapy was not associated with risk of all-cause cardiovascular or cancer mortality during that 18-year follow-up. So this is really interesting and exciting data. Again, a little bit different maybe than what you have learned, especially when you are considering the prototype of someone who is within 10 years of menopause. Now, the DOPS trial stands for the Danish Osteoporosis Prevention Study trial. This was looking at younger symptomatic women. In fact, the average age, I believe, was 47 to 54. And these patients were followed for 10 years. Now, the primary outcome was, in fact, osteoporosis. However, when we were looking at the outcomes for women who are on estradiol and norethindrone, there showed to be a reduction in mortality, heart failure, and MI without any apparent increased risk of cancer, VTE, or stroke. But it is important to note that was not the primary outcome for the Danish Osteoporosis Prevention Trial. So big takeaways, we're looking at younger symptomatic women, whereas in the WHI, we had a slightly older cohort of patients who are in their mid-60s who are mostly not having symptoms. And the other big difference here is they used a different preparation. It was estradiol and norethindrone, whereas in the WHI, we used conjugated equine estrogen and medroxyprogesterone acetate. Just a slight difference in preparation. The KEEPS trial, the Cronus Early Estrogen Prevention Study, also was similar to the DOPS trial, in which we're looking at younger women. In this study, they used oral conjugated equine estrogen, a transdermal estrogen, so an estrogen patch, and micronized progesterone, so slightly different preparations. And both treatment arms showed improvement in bone density, improvement in cardiovascular markers without an increase in blood pressure, reduction in hot flashes, improvement in insulin resistance, improvement in genitourinary syndrome of menopause, and no adverse effects on cognitive function. So again, looking at younger symptomatic women. Now, the ELITE trial done by Howard Hodis was to investigate the physiology behind why are we seeing that younger women are, doing better. So enrollees were given oral estrogen plus vaginal progesterone and divided into two groups, those within 6 years of menopause and those after 10 years of menopause. And the authors were measuring coronary calcium and carotid intimal thickening scores. And they found that the estrogen, when given orally, was associated with less or little progression of subclinical atherosclerosis compared to placebo when it was started in the younger women, less than 6 years of menopause. That's what I mean by younger, but not seen when the women were greater than 10 years out of menopause. And this confirmed this timing hypothesis that there's a 10-year window. And I prefer to use 10-year window over the ages of 50 to 59 because you could have menopause at 52 or 53. So there's a 10-year window in which prescribing hormone therapy is likely beneficial, especially when we're talking about cardiovascular health, since that is such a confusing aspect of the use of hormone therapy and likely not harmful. And again, we're talking about women with no known contraindications to the use of estrogen. Estrogen is a vasodilator. So the hypothesis may be that, when you're younger and you've seen estrogen and you're shortly after menopause, estrogen is going to be a vasodilator. Whereas if you're introducing it maybe 1 or 2 decades after menopause and there is some black plaque buildup at that time, estrogen may be pro-inflammatory at that time. Hence why we see differences between physiology and risks between our women who are within 10 years of menopause and those who are greater than 10 years of menopause. So this is just a slide. It's a little busy showing that there's cardiovascular benefits. Now let's talk about breast cancer as well, because this is a question you're inevitably going to get. Now, interestingly, for the women who took estrogen only, so I remember I said there's two groups, those who took the estrogen progestin and estrogen only actually had a reduction in breast cancer risk that was statistically significant after a 12-year follow-up. So this is a point I always teach to my residents and my students and my trainees because it's very interesting. So a lot of us who are NAMS experts or menopause experts actually think about the progestin component. Now, in the women who took conjugated equine estrogen plus MPA, the news outlets reported a 24% increased risk of invasive breast cancer. We're seeing all sorts of numbers right now in the news about, increasing risks of disease. The relative risk of, 24% is actually an excess case of 2 to 4 women out of 1,000 over 5 years who used Prem Pro. Now, this is actually a very similar risk to those women who drink more than 5 glasses of alcohol a week. So some women are surprised to know they're already assuming that risk, or when you put it into perspective like that, and they're suffering with a lot of symptoms, it might, definitely ease or help them calculate those fears. It's also, there's a greater associated risk if you're overweight or obese. But there is just this deep-rooted myth that still exists among a lot of women and clinicians that hormone therapy is going to cause or give you breast cancer. And I think there's much more to the story. It's very complex. Now, as I mentioned, some women, some of us think it may be the progestin component. So when we use different types of progestin, like micronized progesterone or norethindrone, two things that we saw in the DOPS trial and the KEEPS trial, and actually even it actually had less proliferation of breast cancer cells in vivo. And so that's something to take in mind. In fact, I mostly use micronized progestin. Now, there is a risk of DVT. The risk of DVT is similar to women who use SERM, so tamoxifen for breast cancer risk reduction, or Avista for osteoporosis. So those risks are the same. Also, risk is similar, if not slightly higher, for birth control pills, and definitely higher when women are pregnant. The risk of a blood clot is usually actually highest in the first 6 months and then goes back down over time. The risk is lower if your women are within 10 years of menopause. It's also lower if you use a transdermal, so a patch, spray, or gel of estrogen that is FDA approved, although that doesn't mean everyone should use the patch. It's just an option. And of course, lower doses are safer than higher doses. So there's many, many benefits. We've talked, I wanted to spend some time clarifying some of those cardiovascular risks and clarifying some of the breast cancer risks and, of course, the blood clot risks. But surely your patients are going to have an improvement in hot flashes, in their sleep, in their quality of life, in their bone health, in their symptoms of vaginal dryness or dyspareunia, and their mood symptoms. Now, It's not FDA approved for mood symptoms. Menopausal hormone therapy in the United States is FDA approved. Really for vasomotor symptoms, night sweats, and genitourinary symptom of menopause. However, your patients may surely see an improvement in their mood, especially as in the KEEPS trial, they saw less anger, hostility, improvements in insulin sensitivity, which is quite interesting, although it's not used for primary prevention of diabetes, improvements in their sexual function, and they work longer and they're more productive. And, maybe this means there's other positive effects on some of their other chronic conditions. Typically, my patients are really motivated to go to the gym, to exercise, to be healthy because they just feel much better. So both the American College of OBGYN and the North American Menopause Society now say, and this is really key, there is no longer a time limit on which you must stop hormone therapy. So many of my patients do come to see me. Their clinicians have taken them off their hormone therapy. Sometimes their symptoms return, sometimes they don't. We do consider lower doses as patients age, but this really should be a shared decision-making every single year the patient comes to see you. Certainly, you may want to try to switch to a transdermal or lower that dose. And if this is a little bit out of your wheelhouse, you can certainly send someone to see a menopause expert, and I'll tell you how to do that as well. Okay, there are non-hormonal options. The reason we've spent a majority of this time talking about hormone therapy is because we really do want to understand some of the myths and misconceptions about hormone therapy. And I do think that when we're thinking about risks and benefits, certainly SSRIs, which is what I see a lot of my patients try first, certainly also carry risks as well, and may also not help with all the other aspects such as bone health or genitourinary syndrome of menopause or the brain fog or etc. But certainly patients can try non-hormonal options and there's no right or wrong answer. There's one and only one that is FDA approved, which is Brisdell, 7.5 milligrams. It's very costly. Unclear why. So I often will then prescribe paroxetine 10 milligrams. It's not associated with weight gain or sexual dysfunction. And there are other SSRIs that can be used off-label as well, of which I'll see many patients try. Now, Effexor tends to be a popular one. I'm personally am unclear why. I do think maybe paroxetine 10 milligrams is a great starting place. I think it may have less side effects than Effexor, but certainly venlafaxine, gabapentin, oxybutynin, and clonidine are all options. But again, recall, those are all going to have side effects or risks associated with them, just as the use of estrogen plus a progestin. If patients are having a lot of trouble sleeping and definitely don't want to try a hormone therapy, sleeping agents are helpful. A lot of my patients do well with over-the-counter magnesium. Certainly, they can try melatonin. Certainly, make sure their sleep hygiene as well. Sometimes amitriptyline, trazodone, or Remeron can be options. Now, the 2017 NAMS position statement, again, really highlights that there are benefits for women who take hormone therapy within 10 years of menopause who have no known contraindications to estrogen. The 2017 NAMS position statement is an excellent quick read. And again, most of you seeing adults have patients who are menopausal every single day in your office, so it's certainly worth a quick read. Again, it definitely states that patients who have premature ovarian insufficiency or surgical menopause should be treated with hormone therapy as the gold standard. No longer needs to be the shortest dose for the shortest duration. It should be a shared decision. We talked about all those points. All right, let's do a first case. A 54-year-old, she's a G2P2 with chief complaints of hot flashes up to 20 a day and nighttime symptoms. With her last period 2 years ago, comes to your office reporting of severe hot flashes. She has osteopenia with the lowest T-score of -1.6 and some generalized anxiety. No history of a DVT or PE, and she has an intact uterus. What would you like to start for her? Option A, lifestyle changes. Option B, black cohosh. A C would be citalopram 20 milligrams. And D would be an estrogen progesterone patch. I'll give you about 10 seconds, not 10 minutes. right, 5 more seconds. 5, 4, 3, 2, 1. All right, some last minute votes in there. Okay, so about 90% said the combi patch. Few people voted for the citalopram, and few people voted for, those are the main two. All right. So I would certainly go with combi patch, and I'll go through all of these and explain why. Now, if it's always, we never know what's going to be on the internal medicine boards. Hormone therapy is still tends to be somewhat controversial. Again, for reasons that are beyond the scope of this talk, but the reason I will go from the bottom up, actually. So the estrogen progesterone combi patch is a really nice option. And I do want to use this slide to also talk about what are some of the quick options you can have in your back pocket. And the combi patch is certainly one. Now, I always tell my trainees and my patients that I really do individualize their treatment. There's lots of different ways that we can do it. But if you want to take away, a really nice option would be the combi patch. It's certainly a transdermal, so it's going to reduce the risk for blood clot. It has estrogen and a progestin in it, which this patient needs because she has an intact uterus. It's going to help her hot flashes as well as her osteopenia, especially if she's having 20 hot flashes a day with night symptoms. This is really severe. This is so disruptive, and really, most likely this is going to be a better option than an SSRI for her. So I would definitely start with the combi patch. Now, if she has no known contraindications, this would be a really good option. Remember, she's had 2 pregnancies, so she's had 2 little stress tests, if you will, had no blood clots with those, and that's a really good indicator that she's probably overall at low risk. So citalopram is not FDA approved to treat vasomotor symptoms. It's not going to help her bones. It also won't help with if she had any genitourinary syndrome of menopause, which we didn't ask about, but most women do. We'll get to that next. Again, paroxetine 10 milligrams would be probably my first choice. If the patient didn't want to take estrogen, so if that was part of it, I would say, to try, paroxetine. Again, if she really did not want to take estrogen, then maybe an SSRI. Black cohosh is shown to actually be ineffective in trials and in meta-analysis. This patient has very severe symptoms, and black cohosh is probably not going to be an option for her. Now, I don't think that black cohosh is dangerous, so if patients do want to try it, though, or they tell me it's been helpful, that's fine. I just note it. Lifestyle changes is certainly not going to help this patient based on how severe these are, but certainly she should still do those things in addition to her treatment. So if you just want some takeaways here on some hormone therapy options, there's the combi patch is a really great option. It's an combined estrogen progesterone patch. Another one is Climera, and Climera comes in either Climera or Climera Pro, and the Pro just means there's progestin with it. There's also nice combination of estrogen norethindrone, and that's called, the brand name is either Activella or Mimvi. Mimvi comes in 2 doses, Mimvi Low and Mimvi, and those are really nice options if you're just looking for something to take away from this if you have not prescribed hormone therapy in some time. All right, with the last few minutes, I just briefly want to talk about genitourinary syndrome of menopause. So genitourinary syndrome of menopause is severe vaginal dryness, but not only we're looking at the vagina, but we're thinking about the vulva, the bladder, and all of the lower GU tract. It affects most women in menopause, and it does not need to be a normal part of aging. Now, unlike hot flashes, which may stop because those receptors in the brain are going to downregulate, the vaginal tissue is really actually only going to get worse as time goes on. The scope of the problem is really significant because most people never discuss it with their physician, and most physicians also don't bring it up. And there's many reasons why. There's many barriers, perhaps time, perhaps embarrassment, or some women think there's just no treatment, and that's how they need to. This is now how they need to stay. It's chronic and it's progressive, and it's not going to get better without treatment. And again, this is really a clinical diagnosis. So you're going to see some dryness, irritation, decreased. They're going to complain of dryness with intercourse, etc. You can also see recurrent urinary tract infections because of the change in pH in the vagina after menopause. I actually always show this picture to my patients here. You can see when you look over to the left side, if you can see my little arrow, premenopausally, you're making cells that are making lubrication. Those tissue is very elastic. Whereas postmenopausally, you get a really thin, almost no lubrication during intercourse, and this can be very prone to urinary tract infections. So treatment surely ranges from non-pharmacological treatments, over-the-counter moisturizers and lubricants, to vaginal estrogens, to vaginal DHEA, ospemifene, which is an oral option, and then there's also some off-label options. Vaginal estrogen is extraordinarily safe. We know this because we've done several studies, lots of randomized, lots of meta-analysis on the use of vaginal estrogen. What we see when we use vaginal estrogen is very, very low levels of systemic estradiol, actually similar to postmenopausal women. So we do not recommend checking estrogen levels for women who are taking vaginal estrogen. The risk of breast cancer is almost, there's always more data coming out, but the biggest study just came out in 2019 from the Lancet, looking at 58 studies on vaginal estrogen, showing no increased risk or recurrence of breast cancer with the use of vaginal estrogen. So overall, extremely safe. Now, in the breast cancer patient, this can be a little different, of course. There's a lack of data in the use of vaginal estrogen survivors. Many patients do not want to use estrogen because, they've been told that estrogen can be very dangerous for them, although there are some oncologists now who are considering, especially using in conjunction with a menopause specialist or your internist, vaginal estrogen for patients who are really, really suffering. Other options, of course, lasers, which we're not going to cover because they're not FDA approved, as well as vaginal DHEA, something like progesterone. I'm going to skip over the lasers. All right. I think this is my last case for you. A 62-year-old married female is experiencing painful intercourse dyspareunia. She has residual pain for 2 to 3 days and pain at entry. Her sexual relationship with her spouse is important to her. No cancer history. She does have hypertension and some dyslipidemia. They're both well controlled. Would you recommend over-the-counter lubricants, pelvic floor physical therapy, systemic estrogen, progesterone, or a vaginal estrogen? And I'll give you guys about 10 more seconds. I look at that. I had 330 of you, I think, already vote, and we've got 100% for vaginal estrogen. Absolutely. And this is great. I would definitely, this is my first choice. It's safe and effective. Now, I would consider pelvic floor physical therapy if no improvement with estrogen alone, because we want to retrain those pelvic floor muscles. So key points, we talked about the timing hypothesis, benefits for women who take hormone therapy within 10 years of menopause, different progestins may further decrease the risk of breast cancer, such as micronized progesterone. Transdermal will give you a lower risk for blood clot, but not for everyone. Hormone therapy should be considered gold standard for hot flashes, genital syndrome of menopause, and osteopenia. Individualization is key. And for genital syndrome of menopause, vaginal estrogen is very safe and it significantly improves a genital urinary syndrome of menopause. Thank you guys very much. This was such an honor to be here. I know this was extremely fast, and I know I speak fast. Please feel free to follow me on Twitter, send me any questions. You can also check out my podcast, Women's Health by Heather Hirsch. Especially, there's several good episodes on menopause. So I have about 1.5 minutes to take 2 or so questions.
Thank you so much, Dr. Hirsch. I've been monitoring the questions. There's a lot of interest. I think several people asked about how you target primary insomnia as a symptom of menopause and what suggestions you might have for someone who that is really their primary complaint.
So great question. You definitely want to take a good sleep intake. When are they falling asleep? When are they staying asleep? Is it trouble falling asleep? Is it trouble waking up? And certainly I have my patients record this for a few weeks so they can really understand what that sleep problem is and really work on their sleep hygiene. Of course, remove the TV from the bedroom, go to bed at the same time, wake up at the same time, try to have a worry period in the morning, turn off the TVs, remove the TV from your bedroom, lavender scents, keep it cold, 65 degrees or colder, remove any distractions. After they've done that, I want to try to tease out, is it a insomnia? Is it more of a medical issue? Tease all those things out as well. certainly at that point, if the patient does have any indications for hormone therapy, if you're thinking about trying that for this, especially if they're waking up hot, etc., that's an option. Or of course, try the melatonin, magnesium over the counters, other sleep aids. Sometimes micronized progesterone only, actually without the estrogen, can also sometimes help.
Thank you so much. We're out of time. We have more question and answer at the end of our time together. Thank you so much, Dr. Hirsch.
Thank you guys for having me.